Bismillahirrahmanirrahim. Thank you, Dr. Shahid. And let's start with the management of stroke patients and the role of neurosurgery. I will try to be brief because the people are getting bored probably. And this is our hospital. And as we already know, strokes are of two types. They can be infarction or there can be hemorrhage. Infarction is basically blockage of a blood vessel which leads to an area of damage in front of that area that is supplied by that artery. While hemorrhage is something the blood has extravasated from the blood vessel and it is in the brain parenchyma. So there is a concept that there is no need to rush. It's only a stroke. That stroke is not an emergency. You can treat it as a cold case. So we'll discuss it in today's presentation. This is circle of Willis. You already know that there are two internal carotid arteries. There are two vertebral arteries. They form a circle at the base of the brain which supplies the brain. And what happens in infarction, as we discussed, that there is a thrombus which is there is a thrombus which is lodged into the blood vessel, and it leads to an area of brain damage which is in front of this, which is supplied by this artery. And again, the concept of ICP, again the concept of foramen magnum, again the concept of there is a risk of herniation, and also in cases of stroke, in terms of hemorrhage or infarction, ultimately they can lead to herniation, and ultimately they can lead to pressure effects. Again, the concept of CSF, blood and brain tissue, as we discussed in the head injury, and can ultimately lead to herniations and can lead to again a similar rise in the ICP with increase in the volume. So we discussed about herniations. So ischemia is basically a cascade in infarction. We'll be discussing briefly about infarctions. We have to keep a balance between demand and supply. And in case of infarction, the demand is more and the supply cannot be maintained because the blood vessel is blocked. So the brain doesn't get its nutrients and glucose and oxygen, and that's why that brain parenchyma dies because of that. And this is the sequence of events. Ultimately, this is the influx of sodium and calcium which really leads to infarctions of the brain. And the conventional management and the best medical treatment for infarction is giving antiplatelets, physiotherapy, good control of hypertension and blood pressure, and diabetes mellitus and other risk factors, and lipid lowering agents. This is the usual conventional treatment, and it is regarded under the best medical treatment. You also give the treatment for ICP, and that's how, if the infarction is large, then you need to give the treatment for intracranial pressure as well. We do the investigations for infarctions, try to find out the cause from where the blood clot has come into the blood vessel. The most common source is basically from the heart, and we do the echocardiogram, and we do the Holter studies to judge that if there is any abnormality from the heart which is leading to infarction. We also look for the carotids because there can be plaques in the carotid which can lead to formation of infarction, and we also look for lipid profile in these patients. Recombinant tissue plasminogen activator. This is a drug which really changed the history, and just imagine a patient who comes in the ER with a stroke, with a fallage, and the patient has got a weakness, and you give the drug to the person, and the person walks away from your hospital. So that's a great achievement, because once a patient gets stroke, the patient is going to get the deficit because of that. But this drug, this magical drug, although there are certain criteria, there are there are side effects of these medicines, but I would say this is a magical drug. Unfortunately, this was not available in Pakistan but from last few years it's available, and we are giving it at Shifa as well as other neurological institutes. We are giving it and using it frequently now, and but the patient has to come within 6 to 8 hours time period. So this drug can only be given within 6 to 8 hours time period. If that time period expires and the patient is late, then we cannot really reverse the stroke. And mechanical thrombectomy is also an advancement in the management of stroke. We go just like we do the angiography, we enter through the blood vessel and we remove the thrombus mechanically and establish the flow. We can put in flow diverter, we can use various kinds of devices to establish the flow in the blood vessel. This is a slide to show you how the infarct occurs. If the area is supplied by the blood vessel is damaged, the rest of the area of the brain is damaged because of that. Malignant MC infarction is an infarction in a major area of supratentorial area of the brain, and it becomes a real emergency because it has got, with best medical treatment, it has got 80% mortality. You give all the head and elevation, mannitol, 3% saline, hyperventilation, barbiturates, you do everything, but there is more than 80% mortality, especially in the age group which is less than 60 years age. So the good functional outcome can be achieved by means of decompressive craniectomy, which is a simple surgery. You do a big bone flap, you remove a big bone flap, and make a space for the brain so that it doesn't pushes on the area of foramen magnum. It doesn't pushes on the rest of the normal areas of the brain. There was a discussion about right versus left, because the left side contains the speech area as well. The decompressive craniectomy is not going to reverse the stroke. It is only to save the life and to have an improved functional outcome, but it is not going to reverse the stroke. So there was a debate that on the left side there is speech area, and the speech doesn't only include speaking, but it also means understanding, comprehension, naming the things. So all these functions are lost in this patient. So there was a debate that it should not be done on the left side, but there are enough papers now which are saying and which recommend that there should not be a difference between the right and left sided surgery. I'll not go into the details of these trials. There are multiple trials which are there for these malignant MCA infarction. We have also published our papers in for regarding malignant MCA stroke, and just to show you, this is an MCA stroke, and here you can see that there is a big infarction in the middle cerebral artery territory. Here is the area of anterior cerebral artery, and here is the area of the posterior cerebral artery, and rest of all is the middle cerebral artery area. And you can see the pressure on the ventricles, and there is midline shift. And if we wait in this patient is most probably going to die. So CT angiography can show you the blood vessels which are, for example, internal carotid artery. If it is blocked, it can be seen on angiogram. This is an MRI diffusion weighted, and it is showing the early infarction, and you can see a proper wedge shape of the MCA infarction. This is a operative picture, and you can see that we have done a big craniotomy. This is the dura mater, and this is the brain parenchyma, and you can see a big craniotomy. The principle of decompressive surgery is that you must do more than 10 to 12 centimeter surgery, and you must open the up to the zygomatic arch and the temporal lobe. So if you don't do that, the brain is not adequately decompressed. So the temporal area must be adequately decompressed, and the size of the cranectomy should be large enough. And this we used to do the duroplasty because the initial recommendations were to do the duroplasty, but now the recommendations are you can leave the dura open because there are no major complications if we keep the dura open. So here you can see the post-operative picture, and here you can see that the brain parenchyma is moving out of the bone, and you can well imagine if this bone is there, how much swelling would have been there. So that's all about the infarction. We move on to intracerebral hemorrhage, and intracerebral hemorrhage is basically bleeding inside the brain parenchyma, and which can lead, which is due to rupture of a blood vessel. And there can be various kinds of intracranial hemorrhage. You have already discussed about extradural hematoma, subdural hematoma, subarachnoid hemorrhage. Intracerebral hemorrhages can be into the brain parenchyma, or it can be in the intraventricular space. There are various locations of these bleed. There are typical locations like putaminal bleed or thalamic bleed or the cerebellar bleed. These are typical hypertensive bleed. But if you find a bleed in an atypical location, especially in a younger patient and who is not hypertensive, then it must raise the suspicion. Like in this patient, this is a temporal lobe bleed. So it must raise this. It's not a usual location. So it must raise the suspicion that this patient might have an underlying problem, and you must investigate for bleeding diathesis, and you must investigate for other causes of hemorrhagic stroke, and you must investigate in terms of angiogram to rule out underlying aneurysms or arteriovenous malformations. Okay, so there are risk factors for these strokes, and there are modifiable and non-modifiable risk factors. Male sex has unfortunately has more risk. Increasing age, and Asians have increasing risk. while whereas hypertension, heavy alcohol consumption, these are controllable factors. So we must tell our patient to control these things. So etiology of, as we discussed, there are essential related to hypertensive, and there can be arteriovenous malformation, aneurysm, there can be bleeding diathesis, dural sinus thrombosis is thrombosis into the blood vessel, there can be post-traumatic, and there can be some tumors which can bleed. And tumors which are commonly associated with bleed include glioblastoma and metastatic, and there can be pituitary tumors or meningioma, they all can lead to bleed. And this is a phenomena which happens in the hypertensive patients, and amyloid angiopathy is also an entity which occurs in the increased age group. What happens once there is a hemorrhage inside the brain? Then what happens? This hematoma can enlarge, and this hematoma can lead to raise in intracranial pressure. There is associated swelling in the brain, and it ultimately leads to herniation, and it can lead to, if we do early scan, these patients can have a later development of an increase in the hematoma size. So there are certain factors which predict the hematoma, but most important is early presentation. If a patient has got an early CT scan, and we have done we must remember that this hematoma can enlarge, and we must do the repeat scan depending upon clinical condition. If a patient have irregular shape hematoma or some bleeding diathesis, there is persistent hypertension which is not getting under control, this patient can have enlarge in the hematoma. As we increase the hematoma volume, the mortality increases. Most of the patients present with sudden onset focal neurological deficit, which progresses over minutes to hours, and headache, vomiting, and these patients may have it might occur during routine activities. There is an ICH score which really determines how much is going to be the mortality of these patients, and this score includes Glasgow Coma Scale, age, location, ICH volume, intraventricular blood extension, and ICH score is measured on the basis of that. And as the score increases, the mortality of the patient also increases. We can easily calculate the volume of the clot by means of anteroposterior, lateral, and dimensions of the blood clot in the maximum section, and then we can measure the depth in the coronal section. So that can really tell you, and we can multiply these three measures divided by 2 can give us the blood volume. There are certain advantages of CT scan and MRI in stroke to judge the stroke early in case of infarction. We can do the diffusion weighted images. CT scan is a preferred investigation for emergency setting to early judge the status, and it can be done in the stuporous patient, while MRI takes time and it is good for soft tissue resolution. There are multiple trials for stroke. I don't want to go into details of these trials, Stitch 1 and Stitch 2 trials. Ultimate conclusion was that there are patients who can get advantage from the removal of the clot. And there are certain recent advances. We can use the neuronavigation or stereotactic, and we can use ultrasonic aspirator while doing the stereotactic. The stereotactic frame is basically a frame which really judges and tells us about tumors or infections or blood or whatever we want to hit in a three-dimensional plane. And we can use the ultrasonic aspiration, or we can use irrigation. We put endoscope through this, or we can pass a catheter and again put a recombinant tissue plasminogen activator which can liquefy the clot. Potential advantages are in deep hemorrhages, and it doesn't really damage the brain parenchyma. We can do the hematoma evacuation under the neuronavigation or stereotactic guidance, and we can also use the endoscope to this is a patient, this is one of our patients, and you can see a big clot here, and there is a mass effect because of this clot, and this is a superficial clot. We went through there, and this is lying very close to the motor area. This patient was moving the right side very well, so we went through the navigation, and we removed the clot by means of endoscope, and you can see the postoperative results. So the endoscopic approach is also very good, and it minimizes the minimum craniotomy is required, and we can put in an endoscope through a small hole and can evacuate the hematoma by means of that. The aim of surgery is not to evacuate 100% of the hematoma. The aim of surgery is to reduce the reduce the mass effect, and to reduce the complications of intracerebral hematoma. So at the end, I would like to conclude that there is no need to rush. It's only a stroke is not a right statement. In case of infarction, it's an emergency. If the patient comes to us within 4 to 6 hours, we can try to reverse his neurological deficit. If the patient is late, even then we can do the decompressive craniotomy if it is a malignant MCA stroke, especially in young patients, and we can save more than 80% of the patients. Similarly, if we have an intraventricular hemorrhage, we can put an EVD. If a patient has got an intracerebral hematoma, if it is a big hematoma and the patient's neurological status is good, then we can do the removal of clot by means of craniotomy. We can do the decompressive craniotomy. We can do the craniotomy and removal of the clot by means of neuronavigation. We can use neuronavigation, and we can use the endoscope. And alhamdulillah, we are using it. We have all these facilities available here. Thank you very much.